the stomach. This is hockey stick appearance. You see this is the stomach and this is vein curving away from the stomach. Then a persistent right umbilical vein, you are visualizing it is curving towards the stomach. It is the right umbilical RUV must disappear by 7 weeks, but in certain cases persistent. When in few cases the umbilical vein is occluded, so the persistent right umbilical vein is there. The causes of, there are many, I am not going to discuss about it. Then there are many associations of right umbilical vein, they are the list. Then there can be other 4 vessel cord, 2 veins, 2 arteries. There can be 1 vein, 3 arteries, persistent vertiline arteries. There can be 1 vein, 2 artery duct. You are not taking a flow, putting a Doppler. And then the ischiocyte view of the vessel wall can give an impression of next vessel. Then can be many more vessel cards and which is associated with anomalies seen in conjoints. The important is card with the equal number of vessels at the fetal end and placental end. A division starts at the placental end, and if fails to divide, you will get a 3 vessel card at the placental end and 2 vessel card at the fetal end. This is very important. We must assess at multiple levels. Then the abnormal course and connections of vessels, there are many. And then umbilical cord constrictions, there can be intrinsic and extrinsic nuchal cord around the neck. This is important. There is type A, type B. But the important is to know whether the cord is tight cord. This is important. This is a challenge. You can get a DeWalt sign that is compressing the skin area here in this picture. Then color Doppler, if you put tight cord, you will get increase in systolic velocity. You will get a systolic notch, an absence of diastolic flow, venous congestion, and pre-stenotic dilatation of vein. This is very important. Then there can be a cord-to-cord entanglement. You see mononuclear teams, too many cards are lying at amniotic cavity and they get entangled. You have to see the flow and judge and guide your obstetrician. Umbilical vein varix, there can be intra-abdominal and intra-amniotic varix. Here the picture is an intra-abdominal varix, and then when you see a varix, and you have to put a Doppler to differentiate from other differential diagnosis of the abdomen, chocolate seeds and many others. The demonstration of flow will differentiate it. This is intra-amniotic umbilical vein varix, tortuous-cystic varix. Then there is an aneurysm of the umbilical cord, which is not common, and until it is too big, it does not cause any problem. The knots of the cord, true knot, false knot. False knot is just localized escalation of water jelly. And here is the picture denoting three-dimensional true knot, and you are putting a Doppler, you are getting 2 pictures. Then cord prolapse and presentation, we must see because it is very important when the cord prolapse into the cervical canal and cord presentation, you get there many predisposing factors like nerve vertex, fetal lie, polyhydramnios, cephalopelvic disproportion, multiple gestation, and increased cord length. Then the cord tumors, they are mostly benign, all of them, and mostly all of them are echogenic, except hematoma, which can be hypoechoic depending on the age of the hemorrhage. And here is the vessel, you are getting a hemangioma where it is echogenic, and there is a feeding vessel here. This is a teratoma, have systems without cystic areas, can contain calcification. This is the angiomyxoma, you are getting an heterogeneous mass. And then these are the all cord tumors. Hematoma, it is usually is a venous source of bleeding. The cord is long, can get compressed and bleed, and you can have hematoma formation. Patent uricus is complication in dome of bladder and umbilicus. Then aneuploidy and congenital anomalies. Aneuploidy, you all know, is the presence of abnormal number of chromosomes. And water jelly some plays a role. Aneuploid fetus has a thicker umbilical cord. You are seeing here with result related to increased amount of jelly. One of the possible cause of increased nuchal translucence in trisomy 21. There are many anomalies and aneuploid associated with reduced number of coils, absent coil, volumetous insertion, short length of the card, associated tumors, and SUA, persistent right umbilical vein, varix, omphalocele, 4 and multiple vessel. We already discussed. How to do umbilical artery Doppler? This is actually a topic which should be covered separately, but I have just given a glimpses of it. Zoom the area of interest, apply a color Doppler, narrow the color box, adjust the velocities scale, and apply the pulse wave gate. Umbilical artery, normal umbilical artery, you see in the notes diastolic flow in early first trimester, then you see a little flow diastolic, and second trimester you get a good diastolic flow. This is abnormal, the reduction in diastolic component, further reduction in diastolic component, and absent, and you get a reversal also. Nowadays, we are assessing with the pulsatile index. I have given the high pulsatile index and like that. Then the venous Doppler, the appearance of a pulsatile flow in umbilical vein in SGA fetus. It is a very recognized marker of an asphyxia. There are many more abnormal Doppler waves, which we cannot discuss here. And embryology and anatomy is just a line that forms from 5 to 12 weeks, body stalk, duct, yolk sac, and anatomies. A reference I have given, a detailed full, it will take a long time. Then take home messages. The message which I want to communicate, don't miss a single umbilical artery, don't miss vasa previa, do not miss volumetous insertion, and do not miss abnormal umbilical Doppler. Card on the rec is important, card prolapse is important, you all know. At the end, the fetus is giving thanks to the God that is provided an umbilical card and sonologist, so he is well connected to mother and the entire world. I thank Dr. M.P. Goel, the organizing team, for allowing me to speak a less talked umbilical card. I thank you all for your patience listening and encouragement. Thank you very much.
Thank you, Dr. Shukla, for a very nice presentation. You've covered the topic extremely well. And I would like to